Medicine rarely changes because of a single breakthrough. More often, progress happens when we stop asking the wrong question. For years, we've treated obstructive sleep apnea as primarily an anatomical problem. We identify a narrow airway and then try to keep it open with positive airway pressure, oral appliances, or surgery. But what if airway collapse isn't just about anatomy? What if it's also about neuromuscular control? The same principle applies in critical care. Rather than asking whether Polymyxin B hemoadsorption works for septic shock, perhaps the better question is whether it works for a specific biological subtype of septic shock. And when we interpret pulmonary artery catheter data, are we actually measuring cardiac filling pressures, or are we measuring the pressure surrounding the heart? This week's papers all point toward the same evolution in medicine, moving away from one-size-fits-all treatments and toward physiology-guided care. Welcome back to This Week in Pulmonary and Critical Care Medicine. Every week, we examine the most important new literature in pulmonary, critical care, and sleep medicine, not simply to summarize the results, but to understand how they should influence the way we think at the bedside. Let's begin. Every sleep physician has had this conversation. Doctor, I know CPAP works, I just can't use it. And that's where things usually get difficult, because once CPAP fails, our options become much less satisfying. So when I saw this Phase 3 trial published in the Blue Journal, one question immediately came to mind. Could we finally have an effective pill for obstructive sleep apnea? Now, I'll admit, I was skeptical. We've seen promising therapies before that never change practice. But this study caught my attention for one simple reason. It isn't trying to replace CPAP. It's trying to solve a different problem. For years, we've treated sleep apnea as an anatomical disease. The airway is narrow, it collapses during sleep, so we hold it open with positive pressure. Simple. Except that's only part of the story. Once we fall asleep, the muscles that normally keep the airway open begin to relax. In some patients, that loss of muscle activity is enough to trigger repeated airway collapse. So instead of forcing the airway open from the outside, what if we could keep those muscles working from the inside? That's exactly what AD109 is designed to do. It combines atomoxetine and eroxybutynin to increase upper airway neuromuscular activity during sleep and reduce airway collapsibility. The investigators enrolled 646 adults with mild to severe obstructive sleep apnea who either couldn't tolerate CPAP or chose not to use it. Patients were randomized to receive AD109 or placebo for 26 weeks in a multi-center Phase 3 trial involving 69 sites across the United States and Canada. So, did it work? Yes, the study met its primary endpoint. Compared with placebo, AD109 reduced the apnea-hypopnea index by an estimated 44%, compared with an 18% reduction in the placebo group. Oxygen desaturation index and hypoxic burden also improved significantly. Now here's where it's easy to underestimate the study. The adjusted treatment difference was only 4 events per hour. At first glance, that doesn't sound particularly impressive, but that's the wrong way to look at it. Think about a patient with an AHI of around 20. A 44% reduction can move that patient from moderate disease into the mild range. That's clinically meaningful, especially for someone who isn't using CPAP at all. Another findings deserves attention. The reduction in hypoxic burden may ultimately prove just as important as the reduction in AHI. Increasing evidence suggests that the severity and duration of nocturnal hypoxemia may correlate more closely with cardiovascular outcomes than simply counting respiratory events. But the study wasn't perfect. Despite better sleep physiology, patients didn't report significantly less fatigue. And adverse effects were more common with AD109, particularly dry mouth, insomnia, nausea, and urinary hesitation, although investigators reported no serious treatment-related adverse events. So where does this leave us? This study doesn't replace CPAP. It doesn't even challenge CPAP as first-line therapy. What it does is give us something we've never really had before: Phase 3 evidence for an oral therapy targeting the underlying physiology of airway collapse in patients who can't or won't use positive airway pressure. Whether AD109 becomes part of routine practice will depend on long-term outcomes, cost, and regulatory approval. But regardless of what happens to this particular drug, I think this trial marks an important shift in sleep medicine. The future may not be about finding one treatment for every patient with obstructive sleep apnea. It may be about understanding why that patient's airway collapses and choosing the therapy that targets that specific mechanism. For years, Polymyxin B Hemoadsorption has been one of the most controversial therapies in critical care. Some clinicians believe it's an important tool for carefully selected patients. Others think the evidence has been consistently disappointing. So when the TIGRIS trial was published in the Lancet Respiratory Medicine, the obvious question wasn't simply whether the treatment works. It was whether we finally learned who it works for. Previous trials may have made a fundamental mistake. They treated septic shock as though every patient had the same disease. But septic shock isn't one disease, it's a syndrome. And not every patient has the same degree of endotoxemia. That's exactly what makes this study different. Instead of enrolling all comers with septic shock, investigators selected patients with elevated endotoxin activity, reasoning that if you're removing endotoxin, the patients most likely to benefit are those who actually have excess endotoxin to begin with. The TIGRIS trial was a multi-center, randomized Phase 3 study comparing standard care alone with standard care plus Polymyxin B Hemoadsorption. Unlike most previous sepsis trials, the investigators analyzed the results using a Bayesian framework, estimating the probability that treatment provided benefit rather than relying solely on a traditional p-value. So, what did they find? The results were encouraging. Patients treated with Polymyxin B Hemoadsorption demonstrated a high posterior probability of lower mortality at both 28 and 90 days compared with standard care. Now, before we conclude that hemoadsorption should become routine practice, it's worth slowing down. This wasn't simply a positive trial. It was a different type of trial. Rather than asking, does this therapy work for septic shock, the investigators asked, does it work for patients whose biology suggests they might actually benefit? That's a much more interesting question. It's also the direction critical care is heading. We're moving away from broad syndromes and toward biologic phenotypes. We've already seen this with ARDS, we're seeing it with asthma, and sepsis may be next. Of course, there are still unanswered questions. Endotoxin assays aren't universally available. The logistics and cost of hemoadsorption remain substantial. And while the Bayesian analysis is appealing because it estimates the probability of benefit, many clinicians are still more familiar and perhaps more comfortable with traditional frequentist statistics. So this study probably won't end the debate, but it certainly reopens it. For me, the biggest takeaway isn't that Polymyxin B hemoadsorption has finally been proven. It's that patient selection may matter just as much as the therapy itself. We've spent decades asking whether treatments work. Increasingly, the better question is, who do they work for? And that may be the most important lesson from the TIGRIS trial. Let's finish with a paper that doesn't introduce a new drug, a new device, or a new procedure. Instead, it asks a much more uncomfortable question. What if some of our hemodynamic measurements are wrong? Not because the catheter is inaccurate, but because we're interpreting it incorrectly. Whenever we measure a pulmonary artery occlusion pressure, we tend to assume it reflects left-sided filling pressure. Most of the time, that's true, but not always. Think about the patient with severe ARDS on high PEEP, or the patient with obesity, massive pleural effusions, abdominal hypertension, or chest wall edema. In these patients, the pressure inside the thorax may be markedly elevated, and that extra pressure is transmitted to the heart and pulmonary vasculature. The catheter faithfully records the pressure. The problem is that it can't tell you where that pressure came from. That's where esophageal manometry becomes valuable. As this review in Chest Critical Care explains, an esophageal balloon provides a practical estimate of pleural pressure. Once you know the pleural pressure, you can distinguish the pressure generated by the heart from the pressure simply surrounding it. Why does that matter? Because treatment decisions change. Imagine a patient with ARDS whose wedge pressure appears elevated. Without additional information, you might conclude they're volume overloaded and start aggressive diuresis. But if much of that pressure is actually being transmitted from the pleural space, the true transmural filling pressure may be entirely normal or even low. Now your interpretation changes, and so does your management. The review walks through the physiologic principles behind this concept and highlights situations where esophageal manometry is most helpful, including mechanically ventilated patients, individuals with altered chest wall mechanics, obesity, and conditions associated with elevated intrathoracic pressure. To be clear, this isn't a recommendation to place an esophageal balloon in every critically ill patient. For most patients, conventional hemodynamic measurements remain entirely adequate. But in the complex patient where the numbers don't match the clinical picture, esophageal manometry can provide the missing piece of the puzzle. What I particularly enjoyed about this review is that it reminds us of something we sometimes forget in critical care. Monitors don't make diagnoses. Clinicians do. A pulmonary artery catheter measures pressure. It doesn't know whether that pressure comes from ventricular filling, positive pressure ventilation, obesity, or a stiff chest wall. That's our job. And perhaps that's the common thread connecting all three papers this week. The future of pulmonary and critical care medicine isn't simply about collecting more data. It's about understanding the physiology behind the numbers. Because once you understand the physiology, the right clinical decision often becomes much clearer. Before we wrap up, I'd like to leave you with one thought. When I first started reading the papers for this week's episode, they seemed completely unrelated. One focused on sleep medicine, another on septic shock, and the third on invasive hemodynamics. But after spending time with them, a different message emerged. The future of medicine isn't about collecting more data. It isn't about ordering more tests or adopting every new technology that comes along. It's about understanding the physiology behind the patient sitting in front of us. Because once we understand the biology driving the disease, our treatments become more precise, our interpretations become more meaningful, and our clinical decisions become better. That's what makes reading the literature worthwhile. Not memorizing every number in every table, but finding the ideas that change the way we think. If one concept from today's episode stays with you during your next clinic, your next bronchoscopy, or your next ICU shift, then this episode has done exactly what it was meant to do. Thank you for spending part of your week with me. If you enjoyed today's discussion, I'd really appreciate it if you subscribed to the channel, shared this episode with your colleagues, and let me know in the comments which study you found the most practice-changing. I always enjoy reading your perspectives, and many of the best discussions happen there after the episode is over. Until next week, remember, evidence informs practice, physiology guides it. Our job is to bring the two together, one patient at a time. I'm Dr. Aladdin Sagar, and this has been This Week in Pulmonary and Critical Care Medicine. Thanks for watching.